Welcome, everybody. My name is Susan Lee. I'm a governor for the New York chapter of ACP. Welcome to today's NYACP Immunization Update 2024. I am here with my esteemed colleagues, Dr. Louis Morledge. He is a primary care physician, internal medicine specialist who practices in New York City Midtown. He focuses on primary care and also travel medicine. He has been a member of our NYACP chapter, having served as past New York City Manhattan District Governor. He's also an active member of our HPPC committee, a highly sought after speaker for the topic of vaccines and travel medicine. Also with me tonight is the esteemed Dr. John Hall. He is our governor from upstate Buffalo, where he is an associate professor of clinical medicine. He's passionate about medical education. He not only practices primary care of adults, but also focuses on the complex care of the medically complex pregnant patient, and also is an expert in travel medicine and vaccines. So I welcome them both tonight for this update. So for today's evening, we are going to be discussing just some vaccine concepts and then reviewing specific vaccines, which will include COVID vaccine, flu vaccine, Tdap, RSV, and just a general approach of how to attack vaccines in your office so that you can get all of your patients vaccinated, and some additional resources that will be useful to you. Just some vaccine concepts to review. Vaccines are an amazing thing. Vaccines allow us to use the human immune system to reduce the impact of disease. There are two ways to think about immunization. There's passive immunization, which is basically when an external source antibody or antitoxin can reduce the impact of disease. And this may be polyclonal, for example, IVIG, or monoclonal. And then active immunization, which is basically when you introduce an antigen which stimulates the immune response. And this generally provides a more durable protection. Vaccines can be live, such as the MMR or varicella, or even the influenza vaccine, or they can be inactivated, meaning that a pathogen doesn't cause infection, but this is generally less potent than the live vaccines, and so multiple doses may be required to lead to immunity. We also have to think about the vaccine platform, and this is the method that we introduce the antigen into the patients to establish an immune response. You may hear a lot about adjuvants. Now, what is that? That is the immune stimulant that's added to vaccines to increase immune response. Next slide. Other vaccine concepts to think about. Vaccines were developed to provide protection from diseases with far less risk than the potential natural infection. And vaccinations in adults are a little bit more complicated than those in children. It's not as cookie cutter because we have to think about things like what are the risks for the disease in patients of a certain age, patients with certain medical conditions, patients taking certain medications. And the primary goal is to reduce disease and transmission. And what we know is high immunization rates translate into population benefits, or what we call community or herd immunity. And we need to understand the levels of recommendations that we give to our patients. We can recommend them using evidence-based guidelines, but often in internal medicine, we are using shared decision-making. Next slide. We face a lot of challenges with vaccines as physicians in our offices. These challenges are created by anti-science, anti-vaccine misinformation, especially with social media, which makes this more rampant. Many individuals do not understand their personal risk from infection versus vaccine. People don't make decisions in a vacuum. They are influenced by family, community, religion, media, and the fact that words really matter and how we talk to our patient. But what we know is that using vaccines results in countless savings for our patients, and we need to remind them of this. Next slide. So we will pivot over to a discussion about COVID-19. So take it away.
Before I move into the discussion about COVID-19 vaccines in particular, I did want to take a moment to mention that we intentionally chose 4 common vaccines to discuss today, starting with the COVID vaccine, followed by the influenza vaccine, and then the Tdap vaccine, and lastly, the RSV vaccine. Not only did we choose these because they are common and often encountered in our practices, but we also thought that this would be an interesting piece to discuss in relation to vaccines in pregnancy. And these 4 vaccines in particular are the 4 vaccines that are recommended in pregnancy. And with that, I will talk a little bit about the COVID-19 vaccine. The FDA authorized the newest version of the COVID-19 vaccines, which are referred to as the 24-25 formulation. And the ones that are available in the United States are the 2 mRNA vaccines that we know of as the Moderna mRNA, which is known as Spikevax by the trade name, and the Pfizer mRNA vaccine, which is known as Comirnaty under that trade name. Novavax is available as well. This is still under EU emergency use authorization in the United States. The current mRNA vaccines with the Pfizer vaccine is the KP2 strain variant, and the Moderna is a single valent vaccine of the Omicron KP2 strain as well. There is a little bit of a difference, even though it is a single strain. The Novavax is against the JN.1 variant of Omicron. COVID vaccines should be received by individuals who are 6 months and older. However, we know that the Novavax is under emergency use authorization, and if someone chooses to use this vaccine preparation, that's only been approved thus far for individuals 12 and older. So in terms of looking at what we know about what to do with people that have been previously unvaccinated, they should receive either a single dose of the 24-25 mRNA vaccine or 2 doses of the spike protein vaccine, which is the Novavax, and that should be given at time 0, and then the second dose at somewhere between 3 and 8 weeks. If someone has been previously vaccinated with any other preparation of a COVID-19 vaccine, they can receive a single dose of any 20, 24, 25 preparation, but that should be at least 8 weeks after the most recent dose. I won't review all of these particular considerations. You can see them listed on the slide, but there are variations in the dosing schedules depending upon whether a person is immunocompromised and their degree of immunocompromise. And based on that and which vaccine is used, the dosing schedules may vary. So I would recommend that you look at the most up-to-date recommendations at the time of providing a COVID-19 vaccine update to anyone who may be immunocompromised. It's important to note that Previously, under emergency use authorization, the Johnson & Johnson vaccine was available. This was a viral vector vaccine using adenovirus that is no longer available in the United States for use. mRNA vaccines are liposomal vaccines that contain the mRNA that codes for the spike protein, and these are the ones we know of as the Pfizer and the Moderna vaccines. The Novavax is a protein-based vaccine, and essentially that's created by uh, inserting a modified spike protein gene into a baculovirus, and then that is infected into moth cells that produce the spike protein. After the spike protein is produced, it is harvested, and the spike protein particles are assembled into nanoparticles, which are then injected as the vaccine. Any of the COVID-19 vaccine preparations updated for 24-25 are recommended for individuals who are pregnant, breastfeeding, who are trying to conceive, or may consider conception in the near future. We should administer the COVID-19 vaccine according to the adult immunization schedule that is recommended, regardless of gestational age or whether or not the person happens to be breastfeeding. The general concept is to immunize earlier than later in order to limit any potential fetal or maternal complications, which could in fact include death, which is an increased risk from COVID-19 infection itself. COVID-19 vaccinations do not alter one's ability to conceive. It has no effect on fertility treatment. Therefore, people can receive those vaccines if they are undergoing fertility workup and treatment as well. Breastfeeding timing and patterns should not be altered in relation to reception of a COVID-19 vaccine. And essentially, if the mother does receive a COVID-19 vaccine and is breastfeeding, this does actually provide passive immunization to the newborn as soon as 15 days post-immunization with an mRNA vaccine. And this passive immunity that can be transmitted to the newborn can last up to 6 months. In terms of looking at the benefits of COVID-19 vaccine in pregnancy, approximately 90% of pregnant patients with COVID-19 recover without hospitalization, but we know that of those who do not recover easily, their course can be more complex, longer lasting, and more severe. If we look at this study that was from 2020, it looks at patients that are pregnant versus non-pregnant with admissions for COVID-19 infection. And you can see that the pregnant patients are nearly 3 times likely to have an ICU admission, more than twice as likely to require invasive ventilation, more than twice as likely to need ECMO, and are also noted to have an increased risk of death as compared to non-pregnant patients, which highlights the need for COVID vaccine in the pregnant population. Nearly 90% of babies who are hospitalized with COVID-19 infection were noted to be born to mothers who did not receive the COVID vaccine during pregnancy. This is a recent study that was published in MMWR in September of 2024, again highlighting the benefit not only to the mother, but also to the newborn in terms of reducing morbidity and mortality.
Terrific. John, thank you so much, and Susan as well. we will start on the next topic, which is going to be influenza vaccines. And at the time of the year that we're recording this, which is in the fall, this is an extremely common topic, and there should really be no visit to a general internist's office where this is not coming up during every visit as an opportunity to vaccinate your patients and to offer them the right information to make decisions. To start with, we're going to start with a question, different population, however. Influenza, which of the following patients should receive 2 doses of the influenza vaccine in a single influenza season? A, children 6 to 9 months of age, the first season vaccinated. B, persons 6 months of age or older every year, September to April. Persons 65 years and older who received the standard dose influenza vaccine, immunocompromised persons, or persons planning to travel to the Southern Hemisphere in the U.S. summer season. And the answer is answer A. And this is a new recommendation. 2 doses of the influenza vaccine are recommended in children 6 months to 9 years in the first season vaccinated only. All others should receive 1 dose. And this is pertinent because you may have patients who come in, particularly parents, who are going to ask questions about this to their adult physician, and that may be something that comes up. So once again, 2 doses are recommended in children 6 months to 9 years in the first season they're vaccinated only. Important distinctions during this season: all 2024 to 2025 influenza vaccines are now trivalent. The influenza B Yamagata strain is not included because there have been no reported cases since March of 2020. And the recommendations for the strains that are included in the vaccine, as many of you may know, are usually made by the WHO in February of 2024. There are several different vaccines to consider. The first would be the egg-based vaccines, once again with 3 strains. And each of these vaccines has an H1N1 influenza A, a H3N2 influenza A, and an influenza B included. Next slide. The culture-based vaccines, or the recombinant vaccines, also have 3 strains. As mentioned, it's going to be an H1N1 strain, a H3N2 strain, slightly different, and then finally a influenza B strain. Influenza, and this is a bit newer. Patients with an egg allergy who have hives only, or may have had some mild reaction to eggs, can receive any influenza vaccine. If they've had a more significant reaction, the egg-based vaccine can be used, but the patient must be monitored. A severe allergic reaction to any of the influenza vaccines precludes future administration. And what's important is these vaccines should be administered, especially if someone has a more significant reaction, in a monitored setting, where there's adequate personnel and adequate supplies to address a hypersensitivity reaction if it were to occur. We have many patients who come in who may mention that they've had a reaction. You may probe a little bit more, ask additional questions, and then make a decision regarding what the best choice is for that patient. Next slide. Influenza is advised, the vaccine is advised for individuals 6 months of age or older. In the group who's 65 and above, we usually advise the high-dose vaccine. Ideally, the vaccine should be offered during September or October. But in addition, whenever if someone has not been vaccinated, you should continue to vaccinate or offer that vaccine to people throughout the influenza season, which in some seasons is through the month of March. As I mentioned, continue to vaccinate through the entire influenza season. Vaccination can begin in July or August. However, try to avoid vaccination during September, before September, in patients who are 65 years or older, or pregnant in the first or second trimester. We know that shortly after receiving the vaccine, there can be waning vaccine, and maybe by the tail end of the vaccine, as I mentioned, March and April. And several years ago, we had a flu season where there was a spike in March. Older individuals may have immunity that's not quite as robust during the time that flu rears its head. You can immunize patients much earlier, including in August, if you don't think they're going to have an opportunity to have the vaccine later in the season. Pregnant patients in the third trimester should be vaccinated early. Regarding influenza, there's an increasing number of observational studies that suggest that the vaccine has decreased effectiveness related to the timing of the vaccine, meaning you receive the vaccine, its efficacy decreases over time. Therefore, you want to try to vaccinate just before the influenza season so that the vaccine remains effective during that entire season. There's a balance between the length of protection and the opportunity to vaccinate. You vaccinate too early, you may lose effectiveness at the tail end of the season. And influenza season in the Northern Hemisphere typically runs from October to May, and the peak season is usually between December and February, but that can differ from season to season. The ability to predict what's going to happen during a flu season becomes a bit challenging from time to time. Some of the ways you can follow that in the community are looking at your state health departments, for example, who may publish data on a regular basis. I know New York State does that, where you can look at the flu incidence, usually a couple of weeks delayed, but gives you an idea of how the curves are trending, and that can be a valuable resource for you to counsel your patients. Next slide. Influenza, as mentioned, immunity declines year after year. Therefore, repeat doses do help provide cross-immunity. Mortality reduction with the first vaccine is decreased by about 9%, and mortality reduction with repeated vaccines decreases between 41 to 75%. And there's a 57% reduction in influenza-related pneumonia in patients with the current year vaccine. We are now back to pre-pandemic levels of influenza, at least judging from the 2022 to 2023 season. So it's important for us to really emphasize the need for influenza vaccine in our patients. We know that hospitalizations, depending on the year, have been as high as 810,000, and deaths have been as high as 81,000 deaths in certain seasons when we have a particularly virulent strain. The high-dose vaccine is more effective in seasons when there is a highly virulent strain and severe disease, and less important in seasons where the predominant strain produces more mild disease. However, as mentioned, that can be very unpredictable. Next slide. Influenza and pregnancy, you want to use the inactivated influenza vaccine only, no live vaccine. Can be given safely in any trimester. And influenza during pregnancy increases the risk of hospitalization, preterm labor, preterm delivery, pneumonia, and death. In pregnancy, vaccination is advised during pregnancy. It can be given postpartum. It can be given during breastfeeding. But this is an alternative only to be thought of if it cannot be given during pregnancy. Newborns of vaccinated mothers have lower rates of neonatal influenza, which is a valuable point. Next slide. Moving on to the next topic, which will be tetanus, diphtheria, and pertussis. Next slide. To start with a question, Natalie is a 35-year-old woman who's in the office for her annual checkup. She has allergic rhinitis and intermittent asthma, which have been well controlled, and last needed to use her inhaler in 2023. She received Tdap in 2019 and the Prevnar 20 vaccine in 2022. She's now 32 weeks gestation with her second pregnancy. She received the COVID and influenza vaccines in October of 2024. Which of the following do you recommend for her today? Choice A, the COVID 2024-2025 vaccine. Choice B, the influenza vaccine. Choice C, the Pneumovax 23 vaccine. Choice D, the RSV vaccine, namely the Pfizer vaccine. Or choice E, the Tdap vaccine. And the answer is answer E, the Tdap vaccine. Tdap vaccine is recommended during every pregnancy at 27 to 36 weeks of gestation to reduce the risk for infant pertussis. COVID and influenza vaccines are also recommended for every pregnancy, but she's already received them. RSV vaccine is recommended in women pregnant at 32 to 36 weeks, September to January, for infant protection in their first RSV season. Since 2019, it's now advised that repeated doses of Tdap or Td are safe and effective, and you can use either vaccine. If they've previously had a primary series, then you can receive Tdap, Tdap, or Td every 10 years. Next slide. If someone has not received a primary series, you administer in an adult population the Tdap vaccine now, and then the Tdap or Td at 1 month, 6 months, and a third at 6 to 12 months, and then a Tdap or a Td every 10 years. With pregnancy, a woman should receive a Tdap vaccine every pregnancy. Next slide. For wound management, if someone has a minor or a clean wound, then you can give a Tdap if their last dose was more than 10 years ago. If it's a particularly dirty wound, you should give a Tdap if the last dose was more than 5 years ago. If someone's been unvaccinated with a substantial wound, then you should start a primary series for Tdap with Tdap as the initial dose. Next slide. With both in pregnancy, Tdap and Td can be given safely at any point in a pregnancy. Unimmunized pregnant women should receive an initial series starting with a Tdap at month 0, month 1, and then at 6 to 12 months later. Previously immunized pregnant women, you would give a Tdap vaccine, a Tdap vaccine between 27 and 36 weeks with every pregnancy for passive immunity. And then finally, if a patient receives a Tdap at any other time in the pregnancy, do not repeat at 27 to 36 weeks. Previous Tdap boosters do not provide high enough pertussive antibody for passive immunization, peak pertussis antibody in the first month following immunization, and rapid decline after 1 year. And the highest neonatal antibody titers are noted with Tdap given between 27 and 30 weeks. Cocooning is also recommended for protection of a newborn. All close contacts should receive a primary series or a booster of Tdap as appropriate. This would include parents, siblings, grandparents, other care providers, or healthcare workers. As I mentioned, in presenting the flu portion of this evening's talk, and I'll certainly mention this with the Tdap portion as well, we have patients that come in for many, many different reasons. And as we find out more about how families are expanding or how exposures to infants are changing based on activities, this is an important vaccine to recommend and to try to capture during a yearly checkup or during other visits. And these opportunities, at least in practice, exist all the time to try to enhance immunization rates, particularly with the Tdap vaccine. Thank you, and I will go on to the next topic.
Our next topic is the RSV vaccine, and we know that RSV stands for respiratory syncytial virus. This is a newer vaccine for the adult population in the United States, and perhaps we can provide some new information here. We'll start with a question. Which of the following patients is most likely to receive the greatest personal benefit? That is, those that have the highest individual risk reduction from receipt of the RSV vaccination. Choice A is a pregnant 26-year-old woman with no past medical history at 34 weeks gestation. Choice B, a 50-year-old man with diabetes. Choice C, a healthy 62-year-old gardener. Choice D, a 72-year-old woman with COPD and CHF. And finally, choice E, an 80-year-old man with mild cognitive impairment. And the answer will be choice D. And essentially, the reason for that is that in either choice A and choice B, the RSV vaccine is not indicated. A healthy 62-year-old is likely to be the person at the lowest risk for RSV. And the vaccine response to the RSV is likely to be the lowest in a person who is over 80. Therefore, the most likely correct choice is a 72-year-old with comorbidities as noted. they would receive the greatest benefit in terms of reduction of risk from lower respiratory tract disease from RSV. The newest recommendations for RSV vaccine is for individuals who are 75 and older, and they should receive a single dose. The vaccine is approved for people that are between age 60 and 74, but those are people who are at increased risk for severe lower respiratory tract disease related to RSV. Essentially, those are people in that age range with other comorbidities like chronic lung disease, diabetes, heart disease, etc. There are 3 available vaccines. One is the recombinant RSV F protein and antigen that has an adjuvant with it. We did discuss earlier about adjuvants. The second is a recombinant RSV F protein antigen bivalent that does not have an adjuvant. And then there is a third vaccine, which is less commonly used, which is a monovalent mRNA vaccine. The 2 that you may have heard of the most are the first 2 in the list. RSV can cause substantial morbidity and mortality, particularly in older individuals. The RSV vaccine that is currently available it was first approved for use in the spring of 2023. And we should remember that RSV season generally is between September to the end of January. So in terms of who are the people that should receive the RSV vaccine between the ages of 60 and 74, they're people with medical risk factors, as I said, such as lung disease, cardiovascular disease, diabetes, neurologic disorders, liver disease. Also people with advanced age or residing in nursing homes, general frailty, those types of individuals should also have the RSV vaccine in general, but also at earlier ages. In terms of RSV vaccine in pregnancy, it is recommended that pregnant individuals receive a single dose of the RSV vaccine. The one that is approved for use in pregnancy is only the RSV vaccine, which is the non-adjuvanted vaccine. And it is approved for use in pregnancy to prevent RSV-related lower respiratory tract disease in infants. Again, similar to the idea of using Tdap vaccine in pregnancy, we're using RSV vaccine in pregnancy to provide passive immunization to the baby. The benefit of decreasing risk of lower respiratory tract disease in newborns outweighs the risk for complications related to the vaccine, which are minor and uncommon. The reduced risk can be significant. We see that reduced lower respiratory tract disease in infants at 90 days can be reduced by 34.7% at 90 days and as much as 57.3% by 180 days. And then in terms of severe disease reduction, that can be as much as 91%. Before we conclude the section on the RSV vaccine, there is new information out about what to do with a person who is pregnant again who has already received RSV vaccine. We know in the general adult population, the current recommendation is to receive a single dose of RSV vaccine with no recommendations for repeat doses at later points. When we compare RSV vaccine in pregnancy to Tdap, for example, Tdap is recommended with every pregnancy. There is no such recommendation for RSV vaccine. The data isn't there. There is no available data that would suggest that repeated doses of RSV are to be supported. Therefore, if someone has received a dose of RSV vaccine during a previous pregnancy, that should not be repeated in a subsequent pregnancy until further data is available as to the utility of that approach.
Thank you, John. I feel like I learned a lot just from the presentations that were given. We're going to pivot over to communication and how we talk to our patients, and also about the strategies that we use in our offices to increase immunization rates. Next slide. So we're going to start off with a question about vaccine information. Which of the following is responsible for measles outbreaks in the United States in 2024? A, measles importation from outbreaks in other countries. B, unvaccinated and under-vaccinated US travelers. C, vaccine hesitancy. D, anti-science and anti-vaccine messaging. E, all of the above. And the answer is E. And we actually saw this in New York State. The answer is E. US cases are associated with importation of cases from international outbreaks by unvaccinated or under-vaccinated individuals. There's also been vaccine hesitancy, anti-vaccine messaging. All of these factors are responsible for the decreased rates in many communities across the US. But we did see this in New York, and it was quite scary. Next slide. So we are in a difficult place, and it's challenging times for vaccines. There's been active anti-vaccine, anti-science messaging. We are faced with the social media, which is often not great in providing evidence-based information. Has been ongoing and increasing vaccine hesitance in patients and families. Vaccine information and misinformation is not distinguished. It's hard to get access to vaccine information. It's variable. And not all practices use the best practices to get patients vaccinated. I think another challenge is that not all of our patients have the best coverage to get vaccinations in the office. And there's no one accessible, comprehensive, permanent vaccine record, although we do at Stony Brook have the nicest registry, and that has been a great tool, but not all offices have that. So, John, what do you think that we could do to address some of these challenges?
I think it's important to again speak to people about the importance of vaccinations and the benefit of disease risk reduction and any complications that can occur as a result of natural disease. And we should think about talking to patients about not just themselves, but those around them, and the benefits of vaccination to the people that they care about, who they're around, who they have contact with, that may even have a worse outcome if they should come in contact with the communicable disease that we're talking about.
Yeah, I agree. I found that strategy actually was very effective. Lou, I don't know if you have any other tips.
Certainly, I mean, one of the things that, comes into play depending on the type of office you practice in, whether it's in a, large hospital system, or whether it's in a small clinic, or whether it's in a, and urgent care, is to find opportunities to make it easy for patients to get vaccines, whether it is having those vaccines readily available or knowing which pharmacy in your neighborhood has them readily available and how that process works. Are appointments easy to come by? Will they accept my insurance, et cetera? And then I think it's also, helping dispel some of the misinformation that's out there, which, is partially what we're doing in providing this information to our colleagues. But at the same time, it's important to do that amongst patients as well. How many times during a flu season do we have someone who doesn't want to get the flu vaccine because the flu vaccine causes the flu? And the first time I got it, this happened or that happened, probably within a window where there was no immunity that had developed to the flu vaccine at all. They had gotten possibly the flu itself, but during the period with which the vaccine was kicking in. So I think once again, continuing to stay active as practitioners, being allies for our patients in seeking out resources that make the ability to be vaccinated easier.
Yeah, I find that also if we do have the vaccines in our office, for example, we recently are stocking the COVID vaccine in our office. If I have a conversation with the patient about the efficacy of the vaccine, I would say like my take rate is like 70%, which I think is pretty good. In the past, when patients say, "Oh, I'm going to go get the vaccine at the pharmacy," you just never know. It's probably like 20% of the patients would go and get it. So I agree, having the vaccine readily available matters a lot, right?
Absolutely, or at least having a resource, in the community, whether it be
Yeah,
a pharmacy or another provider who has these vaccines available to make it easy for the patients.
yeah,
Yeah. And to your point, Lou, where you were talking about, the person that said that talks about, I got the vaccine and I got the disease anyway, so what good is the vaccine? Well, the reality is, in terms of vaccine science, it doesn't guarantee that by being vaccinated, one will have 100% guarantee that they will not get the disease. But I think it's important to educate the patient that you may still get the disease, but there is a much less likelihood that you will die from the disease. There's much less likelihood that you will be debilitated from the disease.
That's an excellent point, John.
yep. I would also, sometimes I refer patients to ACP's YouTube site. During the pandemic, they did some excellent videos about medical misinformation and about the vaccines. And sometimes I'll just watch one of those videos with patients. And I think it's been a really educational tool to use in the office and use as a tool for shared decision-making. So yeah, great conversation. You can go to the next slide. So I think the key thing is, and I think we can all agree, is that vaccination is really a team sport. It's from, the moment patients check into the office to the moment they check out. Patients trust their physician. And when they have a conversation with people in the office, including your front desk staff or your LPNs or MAs in your office, really that they trust us, so it has the greatest impact. And vaccine hesitancy really falls along a spectrum. Sometimes it's a concern about maybe something that has happened in the past or a rumor that they may have heard. But, in reality, there really are very few patients who are truly anti-science or anti-vaccine. I would say it's really quite a minority, but it comes down to answering the questions and meeting patients where they are. In your offices, do you use a team sport sort of technique to vaccinate your patients?
In my office, absolutely. I mean, I'm in a small private practice in New York City, and there's firmly a medical assistant and front desk staff who are asking about vaccines. And more importantly, when people come in, they're reminding them what vaccines we have available. including the flu vaccine during this time of year, to hopefully, provide the right details and try, even if they're in for something very straightforward, to capture them as for the flu vaccine.
Yeah, and one of the other strategies that we use in our office, as part of the team sport concept, like you said, is that we have nursing staff that are well versed and educated in vaccines and vaccine schedules. And we've developed a set of standing orders that allows the nursing staff to assist us in administering the vaccines at times that are separate from the patients, that may be separate from the patient's appointments with us as well, in order to catch up on things that they may have missed at other points.
Yeah, we use that strategy too as well, and it's really improved our immunization rates. We also use pre-visit planning. So in our office as a part of what we do as a medical home. And so the medical assistants will actually remind us to discuss, outstanding vaccines with the patients, and they'll start the conversation in the room with them as well. So yeah, great strategies. You can go to the next slide. So vaccinations, I think we can all agree that getting them done is super important. I like this strategy of really don't ask, I think we just need to use every opportunity to recommend. People trust their doctors, and a mnemonic that I like to use in my office is called PATH. And this is very effective in those patients who are vaccine hesitant. But to prepare yourself to be open and empathetic, approach the patient. Can we talk about your concerns about the vaccine? And really talk the talk, be culturally humble, try and understand where they're coming from, what their beliefs are, what their fears are, humanize it, really put a face on the recommendation. I know for me, I humanize it when I say people should get the Shingrix vaccine. I describe, my experience with getting the Shingrix vaccine, and then really have to embrace the long game, because patients may not accept it today, but when they revisit you and you have another conversation about it, maybe they've given it some thought and they may reconsider. So, but it's really important to use this strategy when you're talking to patients and really understand where they're coming from. I don't know if either of you use any techniques or strategies in discussing with patients that you'd like to share.
I think it's mostly just, following more or less the same path that you described to address vaccine hesitancy. It's describing your experience, describing what the protective benefits are of vaccines, and providing access to allow for shared decision making, whether it's access to our office staff to review things, or whether it's access to the vaccine, which we happen to have on site.
Yeah, yeah.
One of the things that I think is important is when we talk about people with vaccine hesitancy, I think it's really important to ask them what is the root of their hesitancy or their uncomfortableness with receiving a vaccine. I don't want to take it upon myself to presume that I know why they don't want to receive a vaccine. So I ask the patient, and perhaps by hearing their answer, we can have a conversation that can lead us to a mutually how shall I say, a mutually acceptable option.
Yeah, I think really just having an honest conversation with them goes a long way. And again, like I said, patients really do trust their physicians, and we are the spokespeople to recommend vaccines. Yeah, you know, any discussion helps. It could be your medical assistant that starts it, or it could be, you know, you're starting a flu clinic and we're giving brochures out at the front desk, but every opportunity to discuss is very important. And the next slide. I just want to remind people that there are many resources to educate yourself about vaccines. ACP also has some wonderful resources, which include opportunities to get involved in QI projects through I Raise the Rates. I know our office has been involved in that, and we have been very, very successful in increasing our immunization rates. Next slide. Some of the resources that are available, and I know, Lou, you mentioned that you use this ACIP schedule. I know personally I've used this Pneumovax app by the CDC. I just wanted to make people aware that the schedules have been really much easier to read. They are color-coded, and they are presented in a very easy and easy way to read and understand. It allows for shared clinical decision-making as well as other considerations. So really take a look at the CDC website and the ACIP website as well. Does anyone?
Those of us that are of a certain age, we may remember the vaccine schedule cards. If you're not familiar with it, the CDC vaccine app that you see on the left is actually an app that shows you those same charts of information, and it's interactive. You can change between recommendations of different age groups, different populations. It even includes travel vaccinations, and is interactive with all the information with special populations and special circumstances.
I think another resource in general is, you know, if you have printouts or QR codes where people can get the vaccine information sheets, that's always helpful, where people have at their fingertips information about the vaccine, what type of side effects they can expect, why this is recommended, you know, and if it's not something they're thinking about that particular day, they can walk away and read about it and consider this, because you can mention, you know, that this is firmly something that has been that is important regarding their preventative health.
Totally agree. Well, thank you for joining today's NYACP vaccine update. I really learned so much, and it was an enjoyable event. And I appreciate everyone's time and especially all of your knowledge and your friendship. So thank you so much for joining us today.
Thank you, Susan. Thank you, John.
Yes, thank you, my friends. It's been a pleasure.
Go get your vaccines.
Go get your vaccines, absolutely.